I'm Melanie, and my partners that are working on this clinical trial with me are Jessica and Monse. So the name of our clinical trial is called Ttru, so it stands for T2 tumor reaction to UHRF1 antibody and some radiation. So the population that we're studying for this is those that suffer from colon cancer, specifically those that have a T2 tumor. This is a type of tumor that has grown to the deeper, thick layer of muscle that contracts the force along the contents of the intestines. So before we get into our procedure and everything, some benefits of this are that it affects cancer cells directly. It's more affordable than other conventional drugs. And it also binds to the specific protein that we want to target. And it will also deliver a dosage of radiation to the cell directly rather than affecting the whole body. So there are some risks that we have found, and it's a low blood cell count or some flu-like signs or symptoms. So right now we're going to actually show you how our method works. You can stop.
So in order for it to work, the antibody will be injected into the IV. And from there, the antibody will then be controlled by the drip rate and down into the patient's arm.
And from there, it'll go into the cells that the antibody is targeting, which is a UHRF1 protein, which will go into that.
Once the drug is administered throughout the body, the antibodies, which is represented by purple, is then looking for the cancer cells and will bind itself with the receptor. Once the receptor is binded with the antibody, it will trigger the production of the protein, which is UHRF1, which will then trigger the cell to become like alerted that it needs to be self-destructed by the T killer cells. So then that is how the tumor will shrink and therefore die.
Our objectives and purpose of this trial is that our main goal is to try to test the treatment for colon cancer, in which the malignant cells are programmed to turn on the UHRF1 proteins that are off to turn on to fight the cancer cells, while also reducing their size through the radiation administered with the antibody. So we came to our hypothesis was mainly that if our antibody successfully diminishes the cancer cells within the tissue, then our trial will become a successful treatment for colon cancer patients. So this treatment differs to other treatments in the fact, so this treatment is better than other current colon cancer treatments because other treatments include surgery or chemotherapy, and obviously surgery is a big thing to go through, and then chemotherapy affects the person's mental state and well-being. So our treatment actually just goes directly to the cell, administers what it needs to do, and it's short, less stressful for the patient, and even more affordable. And another plus of this is that once it goes to the cell, if that cell will educate other cells to prevent the formation of cancer again, and it will reduce the tumor slowly through the giving of radiation. Although it might be slow, it'll actually get rid of it, and it'll give a better lifetime span for colon cancer patients.
So the type of trial that we decided to be used to conduct this clinical trial was a double-blinded trial. With a double-blinded trial, the information is not only withheld from the patients but also from researchers, technicians, data analysis, and evaluators. And this also helps prevent bias between specific patients. See, this patient is doing specifically well with the treatment, rather than we're probably just going to cut off this patient from receiving our medication due to the fact it's not responding well. So the subjects that we decided that would only be allowed to undergo this clinical trial is patients with the R2 tumor without an underlying disease. We decided to choose patients who don't have an underlying disease that also have colon cancer, due to the fact that we don't want any negative side effects happening just because of underlying condition. So we don't want anything to be triggered because of our antibodies, and that it could potentially risk the lives of our subjects.
So the assessment of the safety for the NIV would be there should be a nurse to look for the vein in which the IV will be inserted, while another nurse should be preparing the IV bag. Then there should be a tourniquet being added or applied a few inches above the area that's going to be injected. After that, after putting on the tourniquet, there should be there should be a nurse wiping down the area that's going to be inserted with an alcohol pad, and then after that the size of the catheter should be chosen by based on the patient, on their age, and after that the cap should then be removed from the catheter, and then the skin should be slightly pulled so that the IV can be injected into the skin. While advancing the catheter, a nurse should remove the catheter and should secure the needle to prevent hurting anyone. Then the removal of the tourniquet should be handled in order to prevent damage. After applying pressure to the above catheter, the nurse should apply tape to the IV needle, to secure the needle inside the skin. So there should be additional tape added just to secure it even more. The IV tubing should then be attached into the skin or to the tube while opening the IV line. If there was leaking into the drip chamber, then the IV injection was a success, as well as after that the drip rate should be modified towards based on the patient's needs. And lastly, the nurse should just clean up her area and adjust the patient's drip rate. Additionally, the dosage of the radiation should be accumulated to the patient's necessity, just to keep it clear of how much radiation is going to be provided into the patient.